The truth is, most people who do get colorectal cancer don't have a first-degree relative who's had it. It's mainly something that just happens, unfortunately. So through the years, we've determined that by screening or detecting it early, persons can have a better outcome if we find it early. So it's important to do so.
Our screening recommendations have changed just recently, and it is because there's a crisis that we have in colorectal cancer. There is an earlier onset of disease. It used to be for years that we would talk about screening for men and women of average risk beginning at the age of 50, but that has changed. I will say that again, that has changed. Now, men and women of average risk should begin screening at the age of 45. If you have multiple family members who have colon and rectal cancer, or if you have a history of inflammatory bowel disease like ulcerative colitis or Crohn's disease, you are considered at higher risk and should be screening earlier than the age of 45. So to understand that better, you should be engaging with your healthcare provider about when to begin screening. If you have a family history that is known, if you have a family member that is known to have a mutation in a gene that is called, that causes the disease FAP, familial adenomatous polyposis. That's a long
FAP.
That's a long name. FAP, or something called HMPCC, also called Lynch syndrome. If you have anyone in your family, even someone that's a cousin that has that, that is information your healthcare provider should know about, because maybe you should begin screening much earlier. So having a mutation in a gene that puts you at higher risk for cancers, anyone in your family who has that or you know about it, you should be telling your healthcare provider to know, what does that mean for me? So average risk, we have kind of two tiers or two types of tests. One are called stool-based tests. So those are tests that you can do at home, and you get a little bit of stool, and it's either looking for DNA, so that is a particular type of test you can do, and that is changes in the DNA that you should not see in normal stool, or you're looking for blood. And there's also one called an immunohistochemical test. So we've got these 3 stool-based tests that you can do at home, and they're done either annually or every 3 years, depending on which one. One of our tools to screen for it is outstanding, the best one that we have, and it's called a colonoscopy. And the reason it's so outstanding is because it detects an abnormal growth, but can also remove it at the same time. So it is a therapeutic modality in addition to a diagnostic modality. And so if you don't have any polyps, because it takes so long for these abnormal growths to turn into cancers, you have a colonoscopy, no polyp, you go 10 years before they tell you to return. If you have polyps, then you might have to go at 3 or 5 years, depending, or maybe even sooner, depending on what's found, but it's a diagnostic and therapeutic modality. We're starting to do free colon cancer screenings with our stool-based tests. And you know, that's a new push for us. So we recognize the importance of screening, and that some people don't have the means to get screened. So we can't tell people to go out and get screened and then they have no way to do it. So we offer these free screenings. They're out there, but I would say first be the example, and then talk about it.